Good morning. Good morning, everybody. It is my pleasure to introduce Dr. Nancy Dunbar. Nancy went to medical school at University of Washington, and while there, she came under the tutelage of our former faculty member, Robin Reed, who was an intern at the time. Robin showed her the light, and she decided to go pathology. She then did her residency at University of Washington. I think Robin was the chief resident at that time.
Nancy was my chief, actually.
So Nancy became the chief, and she was chief of both Robin and Mike Clinton. So her roots in this department are deep. After residency, she went on to fellowship at University of California, San Francisco, and we were co-fellows together, and we had a very educational year. And then she went on to Dartmouth, and I came here. And I think Nancy has a really fun talk about her educational journey.
Thank you. Thanks so much for the opportunity to be here. It's lovely. This is amazing, and thank you all for coming. I'll be talking today about transfusion medicine. It's what I do. So I do have some learning objectives in that realm. We'll talk about group A plasma for trauma patients. We'll talk about how we can conserve O-negative blood. And we'll talk about massive transfusion protocol indications. But I recognize that most of you are not transfusion medicine specialists and probably don't care deeply about transfusion medicine. So I actually have some hidden objectives in this lecture that are really meant for any of you, but particularly for people who are in their residency or just starting their academic careers, to share sort of my evolution as a researcher and as an academician and things I've learned along the way that may be helpful to you if you like me, may be struggling with the, I don't know if I can be a researcher problem. So hopefully throughout this talk I'll share some of that with you. I love this quote. Rosalind Sussman-Yellow, she actually won the Nobel Prize for her involvement in creating the radioimmunoassay. And I just love this cheeky comment because it really speaks to sort of what I think we all might experience as researchers. When you have an idea, initially people kind of reject it. They're like, no, that's not, we know that's not right, you're wrong. But if you're right, if you're lucky enough to be right, it becomes dogma. And then of course, if you can get the Nobel Prize, you can share your rejections as part of your presentation. Sort of thumb your nose at them, I guess. But good for her. She's an amazing woman. So as Claudia said, my journey and others in the room started in the Department of Laboratory Medicine at the University of Washington. And I was a clinical pathology resident, sort of trying to figure out what I wanted to do, but pretty early on knew that I wanted to do transfusion medicine. But I had a whole CP residency to get through. And one of the great things going on at the time that I think didn't directly influence me at the time, but later came to be something I was quite interested in, was the field of trauma resuscitation was changing dramatically at this time. We were having a lot of experience with combat casualties in various areas of the world in our military, and people were doing research in that field about traumatic injury. And it came to be recognized that there was an acute traumatic coagulopathy. Trauma patients were showing up into the emergency rooms or into the operating theater, and they were already coagulopathic, so their coag studies were abnormal, and it didn't appear to be just related to a simple dilution effect. It wasn't just that they had gotten a bunch of saline in the field, and now their coags were out of whack. And it seemed, as this chart shows, it seemed to correlate with the injury severity. So the more injured you were, the more likely you were to be coagulopathic. And not surprisingly, if you showed up coagulopathic at presentation, your mortality was higher. So it was a bad harbinger, and people were spending a lot of time at this time, and when this was published, I was in medical school, just trying to figure out, why is that, and what's the mechanism for that, and let them know what's going on in these patients that are injured. Around the same time was this paper that came out, the Borgman paper, which raised the idea of a ratio-based resuscitation in trauma patients, and it really took off in civilian trauma, and still really is something I encounter every day. It's the whole origin of the one-to-one-to-one that you might hear if you have a trauma surgeon on the line demanding a one-to-one-to-one ratio of resuscitation for the patients. This study looked at combat casualties that were primarily penetrating injuries, people who stepped on landmines in the theater and were taken care of. And what they observed was if you had a low ratio of plasma to red cells, you had a higher mortality. And the mortality improved if you got to closer to a one-to-one ratio. Now, this paper had a lot of flaws, right? And this paper, you can see how easy it was to say like, oh yeah, that makes total sense, because if you're spilling whole blood out on the floor, you should obviously be replacing whole blood back into the body. But there's some methodologic flaws here. So first of all, if you die before you get the plasma, then your ratio is off, right? So people who die very quickly don't live long enough to get a balanced ratio of resuscitation. These patients weren't getting resuscitated in the way we do resuscitation in civilian hospitals. We use blood components here. You get a unit of packed red cells, you get a unit of plasma. These trauma patients were getting whole blood, fresh whole blood from walking donors in the military. So what you're giving them is not the same product. So some caveats, but this sparked, this great interest in the coagulopathy of trauma and what's going on and why does plasma seem to make it better. So this has a lot of different names. In this particular graphic, they call it the ACOX, or the acute coagulopathy of trauma and shock. And it's thought to be multifactorial, beginning with the trauma itself, which of course leads to the hemorrhage. There are some underlying factors that you can't really control during the resuscitation, your diseases, your medications, your genetics. But really one of the big drivers is shock. So shock leads to acidemia and hypothermia, which feeds forward into coagulopathy. There's also this fibrinolysis factor consumption, which appears to be unique amongst traumatically injured patients. There's the resuscitation itself and the dilution and the hypothermia that comes with that. So very complex and perhaps, I believe, very different than other non-traumatically injured bleeding emergencies. So I believe that the bleeding in a patient who has a high-speed motor vehicle collision is different than the patient who ruptures their AAA, is different than the obstetric hemorrhage, is different than the gastrointestinal bleeder who has cirrhosis. I think you can't treat all bleeding emergencies the same because the underlying mechanism may actually be different, and we'll get to that a little bit later in the talk. So anyway, all this was happening, and I was a resident, and I had the great opportunity to work with Dr. Wayne Chandler, who's kind of one of the gurus in coag, and I know Robin and Mike know him well. We all just, I mean, he taught us so much. And he would have these projects to do for residents, and he knew I wanted to do transfusion medicine. So he had saved all of these samples of trauma patients as they had rolled into the ED. He set aside their blood samples, and he had this new toy in the lab that was a trauma generation assay where you could add the sample and actually see a graphical representation of the burst of thrombin being generated in the sample. So he tasked me, a resident, to do this project. It was the first paper I ever published in transfusion, and it was actually a paper that people wanted to talk to me when I was interviewing for jobs. Like, hey, this paper just came out this month, tell me about it. So it was good timing. But this is what the thrombin generation shows. So if you take a normal person, just a normal person, and you put their sample in the cup and look for thrombin generation, you aren't going to see anything. We don't walk around spontaneously clotting. That would not be very beneficial for survival, right? You actually have to stimulate normal people with tissue factor. So squirt a little tissue factor in the sample and the thrombin bursts. Now we don't want to have runaway thrombin. We don't want our whole body to clot off in response to an injury. So we have an internal mechanism to put the brakes on that, shut it off, keep the clotting close to the source of injury, and then the thrombin generation turns off and goes back to normal. That's what normal looks like, okay? We were comparing thrombin generation in trauma patients, and we were expecting them to look like people who are coagulopathic, like people who might be taking warfarin. So factor deficiency people, these trauma patients should have a thrombin generation potential that might be similar to that. Like if they're dilute and they're prone to bleeding, maybe the reason early plasma is beneficial is because you're restoring some of those coagulation factors. What we found is actually very different. So this is what we found in trauma patients. First of all, you notice it doesn't matter whether you put their own sample in and do nothing or squirt some tissue factor in. They are primed and ready to clot already. So the whole idea that they're coagulopathic because they don't have the coag factors and they can't clot really isn't supported by this. It's not the fact that they can't clot. The other observation is their turning off curve is not symmetrical as it was in the normal, so that it's slower to clot, to turn off the clotting. And this is consistent with looking at traumatically injured patients, especially those in the military theater who survived the initial resuscitation. Many of the complications they go on to have are thrombotic complications. So their system is deranged in a way that's different than I think we understood it to be. And maybe they don't need plasma to replace coagulation factors to help them clot. Maybe they need plasma to restore balance in their hemostatic system so that they can prevent the runaway clotting that's happening, potentially. So that was the first time in my sort of very early career where I thought, whoa, we were thinking about this one way, and now we actually have data to help us, think about it in an entirely different way. Yes, early plasma does seem to be helpful, but maybe not for the reasons we thought. And that was kind of my first big discovery, wow, there's still a lot to learn out there. And there's still stuff we can discover. So I took my next journey off to the University of California at San Francisco, and the research I did there wasn't really related to what I want to talk about in this talk, but I show this picture because I have a very clear and distinct memory of being with Dr. Cohn in this very courtyard. We were walking from a class we were taking on how to be an academician, back to our offices, and we were bemoaning the fact that academic medicine seemed really hard. And I think at least I remember saying, I'm not going to speak for Dr. Cohn, but I remember saying, there's no way that I'm going to do research. I don't want to do research. I just want to go work at a blood center and, I don't know, push paper around. This seems too hard. And I don't know. Do you remember that conversation?
I remember that conversation. We both were destined for
We were both like, this is ridiculous. These people are crazy. I can't write 10 papers a year. What are you talking about? Where do you find the time to do that? But anyway, nevertheless, I took an academic position. And I went off to Dartmouth Hitchcock Medical Center in the middle of nowhere in New Hampshire. And I found myself a newly minted academician who now is expected to do research and publish papers and how do you figure out how to do this? I had this one paper in transfusion, and I had a lot of help from Dr. Chandler, and felt a little bit at a loss to where to go from there. So a little bit about Dartmouth. We are kind of, if you think about Vermont and New Hampshire making a box, we're kind of straight in the middle of the box, and we're surrounded by Maine, Quebec, Eastern New York, and Northern Massachusetts, and that's kind of our catchment area. We're very rural, so we bring patients from quite a distance, and we are a level 1 trauma center. So at the time I arrived at Dartmouth, Dr. Gupta was there, and he and I started working on trauma patients and management of traumatic bleeding. We had helicopters, coming in all the time, bringing people from all over the place. And we had this really unique system. And if you're a resident here, don't panic. Every time I give this talk, people freak out about it because they think that they're going to be asked to do this. Forever at Dartmouth, for as long, even before I've been there, we have had residents in pathology come to the bedside for all bleeding emergencies. In the middle of the night, on the weekend, Whenever they come from home, that's one of their on-call duties. And it terrifies them. It's not why they went into pathology, to come and do bleeding emergencies. And the first times they do it, it's really terrifying, and in the end they feel really empowered, and it's one of their favorite things about their training. What they do is not rocket science. They make sure that the coolers are not empty. They're talking to the blood bank, getting blood in the room. They make sure labs are being drawn so we can do goal-directed resuscitation. They make sure that when everything's said and done, that the blood gets taken back to the blood bank, and they make sure it's stored appropriately so we don't have to throw it away. They work really closely with the people taking care of the patient, and they serve an important role, but they're not, actually doing the resuscitation. So anyway, I was junior faculty, realizing that this was an expectation, and you can't really teach someone how to do something if you don't do it yourself, right? And I had never been asked to go and be at the bedside for a bleeding emergency, so I started going whenever I could. And the other thing you should know is based on a lot of that early trauma research I had showed you, we had a massive transfusion protocol that was designed for trauma. It has the unfortunate name of the TATA, the Trauma Activated Transfusion Algorithm. My boss, Dr. Ziggy Szebrakowski, is Polish, and he doesn't understand what TATA means. He just thought it was a clever acronym. So anyway, we have the TATA. And the TATA does give you a one-to-one-to-one resuscitation at the end, so we have that. But as I was going up to these bleeding emergencies and waiting for that first batch of plasma to come, I was realizing there is an early deficit, or there was an early deficit in the plasma, because the red cells would immediately go up to the bedside in the TATA, and the units of plasma would go into the THAR, the water bath, and it takes about 20 to 30 minutes to get them up to the bleeding emergency. And that, to me, as the person at the bedside waiting for the plasma to arrive, was very distressing. And I always feel like there are feelings. I feel like it's taking too long to get plasma to the bedside, but I need some data. I need data to know whether that's true or not. So my very first attending project, just sort of out of necessity to convince myself, do we have a problem, was looking at the TATA cases we'd had in the recent years, and I really only cared about the patients that got a lot of blood. So I kind of picked a cutoff of at least 6 units, and then if you got more than 10 units, you were kind of in the high group, and 6 to 9 in the low group. And I actually just looked at the time from when the TATA was activated to when the first plasma dose was shipped. And not surprisingly, the difference was about 26 minutes. That's how long it takes to put plasma in the water bath and thaw. What gave me distress was that the average number of red cells that were up in the room before the first plasma was sent was 8. So you could give a patient 8 red cells before any plasma was available. There's one on there that says 0. That might have been a case where we happened to have some thawed plasma lying around that had been thawed for somebody else. But this one, 24 red cells without any plasma in the room, is too much. You've essentially replaced that person's blood volume several times over, and they don't have any coagulation factor really to speak of once you've transfused them that much. So that made me realize, on paper, we have a one-to-one-to-one strategy, but in reality, we don't, and we need to fix that. So I had to think outside the box a little bit, which is my next tip to you as a budding researcher. Sometimes you have to think outside the box. And I had been, sort of taught, as we are taught in medical school, this classic paradigm about, what's the recipient's blood type, what's the donor type, and what's safe to give. And this is very heavily weighted towards giving ABO-compatible red cells. Like, you never want to give someone an out-of-group red cell because you have a hemolytic transfusion reaction and your patient could die. But if you use this kind of classic paradigm and you apply it to plasma, it sort of means that those two risks are the same. So is the risk of giving incompatible plasma truly the same risk as giving incompatible red cells? Well, if you look at what we actually do and you break it down by components, again, the plasma paradigm is reflecting the red cell paradigm, but then you get to platelets. And it's just any. It doesn't make sense, right? Platelet is a bag of plasma. It's 1 unit of plasma. So why do we have to be so rigid here and anything goes here? Well, it's because platelets are only good for 5 to 7 days, depending on what you're doing for your shelf life. And we just don't have the luxury of having enough platelets on the shelf to give everyone an ABO match. So what we've discovered is there's a low risk of hemolysis, but we're not killing people. And we sometimes have to cross those ABO barriers. Sometimes we titer them. So here's Dr. Shepardkowski, if you know him, the founder of the Tata. And here's a lovely platelet. So the first thought I had is, gosh, maybe we need to think about using group A plasma and keeping it thawed all the time for our trauma patients. And this idea was not new to me. I knew that Mayo Clinic had been doing it for years. I knew that Penn State Hershey had been doing it for years. And they were like us. They were rural trauma centers that could not get enough group AB plasma to have it thawed all the time on their shelf. Didn't have necessarily enough volume to use that AB plasma for trauma patients. And they had just said, you know what, we're going to play the odds. Most patients are O or A blood type, so A plasma is fine for them. If you happen to be the minority that's a B or an AB, we're giving you some A plasma while we're giving you group O red cells, and you're probably going to be fine. Okay, so we went to our transfusion committee and we told them for all these reasons, we think we need to have thawed plasma on the shelf. We know we can't make thawed AB happen. So other centers are using thawed A. We know that we give incompatible platelets all the time. We think the risk is low. And we want to propose that we're gonna use group A thawed plasma. And the transfusion committee agreed. And we switched our Tata to include 4 units of group A plasma immediately available with the first batch when the Tata is activated. And if you need more, these ones will either be type specific if we have your type on file, or we'll put group AB in the THAR as soon as the activation happens. And then, we'll keep you on AB or type specific after that. So we took the leap and we did that. And then a couple years later, this is give me the grade A plasma. So then my next advice to you as a researcher is, it's normal when you start out that you do research kind of in your center. Like, I've got a problem here, I need to solve it, what can we do here? But eventually you're going to need to expand your horizons and go outside of your own institution. And so I had this idea that I wanted to look at how many other places were using group A plasma and whether there were enough people to come together and collaborate to see whether there was any way we could show that that might be safe. So the first thing we did is a survey. We sent a survey to all the level 1 trauma centers. We had to kind of cyber stalk them and figure out who the people were, who the medical directors were of all the trauma centers, asking them, like, are you using group A plasma for patients of unknown blood type? If so, are you titering it? Do you have a limit in how many units a patient can get? And so we sent it out, and we were pretty surprised by what we learned. So we sent it to 121 directors of blood banks. We got about a 50% response rate, which is actually pretty good for email-based research. Most of the places that responded were level 1 trauma centers. I think the designations, you can lose your designation, so maybe one person has switched down to a level 2. They were mostly urban, as you would expect. And we had a pretty good representation of the US. So we weren't just looking at practice in one geographic area, but we had responses from all the regions. And what we learned was that 97% of the centers were keeping thawed plasma on the shelf. Like us, they probably realized it takes too long to thaw. Okay, and they had a mix of what they had. So the most frequent was 30% that had group A only. Some people had A and AB. Some people had all 4 blood types. I'm guessing those are the really big trauma centers, like Crowley Shock Trauma in Baltimore that get like 10 traumas a day. Those people can afford to have thawed plasma on their shelf of all blood types. And there were a few holdouts that were thawing AB only. Okay, so that surprised us. More people were using A than we expected. And there were 49 that had Group A available, and the majority of those were using it for patients of unknown blood type, like us. And almost half of them had only implemented it in the last 12 months. And this was the most interesting because at Dartmouth, we're super, super conservative. We titer the plasma, we limit it to 4 units, but our colleagues, 62%, no limit to how much Group A plasma you can get. And just keep dumping it in because you're getting Group O red cells anyway, so who cares? And most of them aren't titering it. And when I ask people, why don't you titer? They say, well, most of the time when I titer, they're low titer, so why bother? Like, the odds of getting a high titer is kind of 1 in 100 or 1 in 50. Why do I need to look for that needle in a haystack? So that surprised us. That was exciting. And that actually led us to write this paper. Sorry for the ribbon. I just found out that this paper is getting awarded at the ABD meeting as the best paper in 2017 in transfusion, which is really cool. And I never, ever imagined when I was in that courtyard with Dr. Cohn that I would, let alone be a researcher, but get a best paper from there. So that's what the blue ribbon is. But the motive of doing this survey wasn't just to figure out what people were doing. It was to find people who were doing what are we doing, and then to collaborate with them to do an actual study. And this was really my first project that I kind of conceived on my own that was outside of something that I could control within my institution and collaborate with other people and really kind of do something that really was research. So what did we do? We had a study question of whether we were hurting people, right? If we're giving Group A people to people who are potentially Group B or AB, are we causing any harm to them? And the signal we're looking for is overall mortality. Are they having increased overall mortality any more so than the Group A patients for whom that plasma is type specific? Okay. We wanted to look at traumatically injured adults who got admitted where Group A plasma was used. They had to get at least 1 unit of Group A plasma transfused, and we categorized them into an identical group of patients, which were the Group A patients, and the incompatible group, which were the Bs and the ABs. This was, of course, their blood types were known during the resuscitation at some point. We didn't include the Group O patients, and if you do coag, you know that Group O patients have some differences in their levels of factor VIII and von Willebrand factor and things that could confound the study. So we just threw them out because Group A plasma is neither identical nor incompatible for the Group O. We wanted to collect all their information about their age, their gender, their ABO type, how they were injured, what was their injury severity score, and how many blood products did they get transfused in the initial resuscitation, which we defined as from the time the first blood product went out until there was a gap of 6 hours between any more transfusions, because you can imagine the initial resuscitation and then maybe the next day, kind of the top of transfusion. We just wanted to capture the initial resuscitation. Our outcomes, our primary outcome was the overall survival, and in trauma there's this really great scoring system called the TRIS score, which incorporates your age, your mechanism of injury, and your ISS, and it gives you a predicted survival. So if you come in with a predicted survival of 50%, then you can do some statistics around did you survive better than predicted or worse than predicted. We also wanted to look at 24-hour survival in case there were some early harms associated with the incompatible plasma that we might be able to see a signal, or length of hospital stay as a marker for some morbidity related to the incompatible plasma. So these were our two populations. We were able, with getting a ton of centers to collaborate with us, to come up with over 1,000 patients, about 800 in the identical group, those were the Group A patients, and about 354 in the incompatible group. And that powered us to show about a 10% difference in mortality if we were going to find it. Our patients weren't different in terms of age or gender, but there was a difference in the mechanism of injury. So the Group B and AB patients tended to have higher rates of penetrating injury. but the TRIS survival score does incorporate the mechanism of injury. So even though we recognize that was a difference between our study groups, and I would also say people with penetrating injury do have lower survival than people who experience blunt injury. So there was a small difference in that population. When we looked at the probability of survival when they rolled in the door, they were very, very similar. In terms of the total number of blood products that they received, all very similar, except, as you can imagine, the group A patients received more group A plasma, because when you switch them to type-specific blood, they keep getting group A plasma, the others get switched to something else. So that difference was not unexpected. And then here are our results, and they're all not significant, no difference, okay? So no difference in hospital mortality, no difference in early mortality, and no difference in hospital length of stay. So it doesn't appear that this practice of using group A plasma early in trauma is harming people in a frequent enough way to be able to detect it by these measures. So our conclusions that the survival and early mortality weren't different, and that we felt like this supported a growing body of evidence indicating that it's safe to use group A plasma in trauma patients. And you know, if you're lucky enough to have access to an unlimited supply of AB, then you should probably use AB.
Right.
But if you're like us and you don't have that, and you're thinking, well, is the alternative to wait 20 minutes to thaw type specific or to send something up right away, I think this might tip you into feeling more comfortable with using the thawed A. All right, so now I'm going to switch gears and get you even more out of your comfort zone. Just a little out of your comfort zone, because that's where awesome things happen. My next idea was to think about O-negative shortages, because, and this isn't specific for trauma patients, but it seems like every summer I get a frantic letter from my blood supplier saying, we don't have enough donations to support our Oneg standing orders, and we're going to cut your orders by 75%. And there's essentially nothing you can do about it, because I think that's because we rely a lot on our blood collection system on high school donors, and when it's summer, school's out, and they're not donating. And then I was having regular days in the blood bank where our O-negative inventory was getting down to critical levels. We like to have 20 units of Oneg on our shelf at all times, and most of the time we're well below that. And when we get to 10, we start to get pretty panicky about whether we can actually support our patients. So I think this trend is going to get worse, not better. So I started thinking about O-negative inventory management and utilization and what we could do during shortages. So as a background, you know that O-negative blood is a precious resource. It's the universal donor type because we can give it to anyone. Many of us already struggle with O-negative shortages, and we might automatically switch people to O-pos as a matter of course. During bleeding emergencies, most typically, many places automatically switch males and or females who are postmenopausal. The reason we try to protect women of childbearing potential is because if they make an anti-D antibody, it can cause hemolytic disease of the fetus and newborn, and we'd like to prevent that because that could cause intrauterine transfusion, very high risk, very expensive. So we already do that, and in fact at Dartmouth, if you have to get a blood transfusion in the helicopter, you get O-pos. Doesn't even matter if you're a 15-year-old girl, you get O-pos. And if you survive your traumatic injury, we'll deal with the anti-D later. And many other places are doing that, and even though we're doing that, we still have shortages. So that's not enough. What else can we do? Well, the goal of the study was to look at utilization and think about age and location-based switching for routine transfusions in O-negative patients. This is really hard for people to wrap their head around. This is me saying, I know your blood type is Oneg, and I know that you need a transfusion today, but I can't give you Oneg because I don't have enough Oneg on my shelf, so I am going to give you O-pos. I'm going to intentionally expose you to the D antigen and take the chance that you might make an anti-D antibody. So who do I do that to? How do you decide who is going to receive that? So we needed data. So we got a lot of institutions, 31 institutions from around the world to give us data about a year's worth of transfusion and all the units they transfuse. and what the blood types of the units were and what the blood types of the patients were. And you can see that most of us are using about 9% Oneg utilization. Places where there is more of an Asian population, it's much lower. So we had a very large data set from Asia that had essentially like 1% Oneg utilization. It was not helpful, so we didn't include it. But places like the US and Europe are kind of in this 8 to 9% range. And that's actually better than the 2015 survey of blood utilization looked at like about over 10% utilization of Oneg, even though our supply is only about 8% of the donors. So we are using it about that much, and there's differences. Some people are using a lot. So who gets the O negative blood? Well, we know that, oh, and I'm sorry, this always, it looks great on my computer, and then it does something weird when it goes onto someone else's computer, but this is right. So we know that a large proportion of our Oneg goes to non-Oneg people for a large variety of reasons, and there's a whole study called the group study that looked at the reasons why. So 44% of our Oneg goes to non-Oneg people. Either it's about to expire on the shelf and they don't want it to go to waste, or they're giving it to a neonate, or they're giving it to a sickle cell patient who has lots of antibodies, or they're giving it to a bone marrow transplant patient. There's lots of reasons. But 56% of the Oneg that we use goes to Oneg people. And sorry again for the same thing. I looked at it last night. It looked great on my computer. Interestingly, most Oneg patients get Oneg. So these are Oneg units transfused to Oneg patients. 88% of the time if you're Oneg, you're going to get an Oneg unit. But 12% of the time, you're going to get an O-pos unit, right? And you might think, well, that's just because they rolled into the emergency room and we had to switch them, or they were using so much that we had to switch them. But interestingly, when we looked at other blood types who got out of group, so if Rh negative people getting Rh positive blood, it was only 1%. There's a difference, right? That can't simply be explained by you're using too much Rh negative blood, we're going to switch you. So this actually shows you already that our O negative patients are already being impacted by O negative shortage. Because 12% of the time they're not getting O negative blood, compared to an A negative blood, only 1% of the time are they not getting A negative. So that's pretty exciting. And
what's the frequency of O negative in the population?
It's about 8% of the donors right now. Yeah. So then I thought, okay, if I was going to be rational about routinely switching patients in shortage, I need to know who's using the blood, right? And age is an interesting marker. So you can see, and I broke it down in 2 different ways. Red is the total amount of Oneg being used, and blue is the amount of Oneg being used by O negative patients. Very little of our blood is used by people less than 50 years old. So the majority of people using blood are older people, and that's good because if you're worried about exposing someone to the D antigen who's going to have childbearing potential, these are the patients that you most likely don't need to worry about. Okay, so older folks are using most of our blood, and that was not unexpected. Interestingly, I did want to say that we quibble a lot at different places about your switching age for women. Like, do you switch women if they're 50? Are they 45? Are they 55? The reality is these people use such little blood, it doesn't matter. Just pick a number. Pick a cutoff. It doesn't matter. You're not saving, whether it's 45 or 50, enough blood to make a difference. Where do people use blood by location? Well, not surprisingly, the hospital ward, which probably includes your hem-onc ward, uses the most, and then it's second, followed by the intensive care unit. And we picked the intensive care unit as our target intentionally. So we know that people in the intensive care unit have a much lower chance of living a year beyond that moment than a person in the hospital ward. Okay, so these people are at higher risk of dying, and they're using a lot of O negative blood. So potentially that was our target of, okay, if I don't have enough Oneg on the shelf, instead of maybe switching my operating room or my ward patients, maybe I switch my intensive care unit patients, because if they make a D antibody, I can deal with it. They're not necessarily likely to require ongoing long-term transfusions as maybe a hem-onc patient might. So we picked them as our population of interest. And we did the same kind of graph by looking at just people in the ICU by age. And the bottom line was if you wanted to reduce your Oneg utilization by almost 10%, if you needed to, you could give OPAs to all ICU patients over age 50. You wouldn't do it all the time, but you could do it if you had an extreme shortage. You could just say, okay, we're under shortage now. Everybody in the ICU over age 50 gets OPAs if they're Oneg. And if they make an anti-D, they make an anti-D. That's almost never associated with an intravascular acute reaction. They do clear those Rh positive cells, and you do need to provide Rh negative in the future. But this to us was some rational data of what do you do on that day when your supplier says your standing order is cut and you have 5 units on the shelf. That's where you go. This is the last study I'm going to show you. I don't actually have any sense of what time it is. Oh, we're doing fine. Yeah, we're doing fine. 5 minutes. I have like 5 minutes left. It's perfect. I picked this quote because when I was a researcher in medical school, I actually met Clint Eastwood. He hosted us down at his ranch for some big medical student symposium, and I just so clearly remember when he came to our table and shook our hand. And so you never know where research is going to take you. Pretty cool. So the last study I want to mention is a study that I'm just about to submit to transfusion. We've just finished writing it. It's the MTPU study. Because again, as I think outside the box, one of the things I've been struck by is we do this 1-to-1-to-1 transfusion for our trauma patients, but everyone else who's bleeding wants the 1-to-1-to-1 too, and nobody really knows if that's the right thing. Like, just because they're bleeding doesn't necessarily mean the mechanism is the same. So I wanted to first get some data of who's using massive transfusion protocols, because we don't have a lot of evidence that the 1-to-1 or 1-to-2 ratio improves outcomes in populations that are not traumatically injured. So the question's pretty easy. What proportion of patients are traumatically injured? And then that leads to the next question, which I can't answer with this study, is are you going to do fixed ratio for those populations? Is there evidence or some mechanism or rationale for why that might be? So we got a ton of hospitals to give us data on almost just over 4,000 activations, and surprisingly, trauma, it's the most frequent, but it's only 42% of the people using the massive transfusion protocols. Surgical bleeding is very high up there, and I have to say for like a ruptured AAA, when I go to those bleeding emergencies, they're almost never coagulopathic. They have a hole in their aorta. They have a hole, they're bleeding, but they're not coagulopathic, and they can get 10 units of red cells before I even start to see their INR drift up. So they don't necessarily need 1-to-1-to-1. GI bleeders, as you know, if they're cirrhotics particularly, their INRs start out really high anyway, and their platelets are always low, and they're not necessarily, their whole system is deranged. It's very hard to correct them. Obstetric bleeders, I always give cryo, because the normal fibrinogen level in a term woman is actually like 800. So these are all the different people using, and I think this sets the beginning of someone, maybe someone in this room, trying to design a study to figure out whether these people need different approaches to their resuscitation. Is there something different about each type of bleeding? I'm here to the end now. I hope that this has been enjoyable for you. These are my official conclusions. If you can't keep baby plasma, then you should think about keeping A. It appears to be safe. If you have O-negative shortages, one possible potential way to reserve some is to switch your elderly ICU patients. And think about your massive transfusion activations, because most of them are not for trauma patients. And I think we've glommed onto what we do in trauma and kind of creeped it over to everyone else, and that might not be the best thing for those patients. Here's some lovely pictures I took in Italy recently, and you can see Dr. Cohn was there amongst us. For my hidden agenda, I think this is what I want to leave you with. There's still a lot to learn. Keep asking questions. If something is bugging you, it's probably a good thing to want to do some research around, or at least get some data. You can do research. You can. We all can. Collaborations are the key, and the joys in the journey. So start the journey. I think you won't regret it. And I think that's all I have. This is where I leave you. This is the Wisteria Walk in Florence. Thank you.
If we have some time for some questions, John?
I really enjoyed your talk. Thank you very much. I'm a retired pathologist, and my career was spent at Hennepin County Medical Center, which is the major trauma center, level 1 trauma center in Minneapolis. And I started there in the early 70s. And for the next 30 years, I was at the bedside for essentially for every massive transfusion that we had.
Wow.
And by the late 70s, I actually instituted a massive transfusion protocol. So we monitored this fairly well. And at that time, we didn't understand traumatic coagulopathy. So when I set this up, I started doing coagulation studies on a very regular basis. And we were able to get coagulation study results within 10 minutes of the time that
Wow.
they were drawn. And so
Yeah.
we monitored their coagulation studies and told the clinicians basically what to transfuse. And our general impression, although unfortunately we didn't study it systematically, was that a 1-to-2 ratio was fine.
Yeah.
We got very good results with the 1-to-2 ratio. So that's my comment. I have a question to ask you, which came out in your talk. Do you think that pathologists should be involved individually on every massive transfusion in the hospitals in the United States?
Okay, so first I want to address your experience and say I think you're right about the 1-to-2. I think the proper study tried to answer that question. And so when I am with a surgeon at a bedside and he's demanding or she's demanding a 1-to-1-to-1, I don't feel like that's necessary. And as long as I'm in the 1-to-2 kind of range, I'm comfortable with that. Do I think that a pathologist should be involved? Yes. I think there's a lot of benefit. I don't know feasibility-wise if we can always be at the bedside, but I think a phone call.
At least on the phone.
Yeah, to say, hey, what's going on? When did you check labs? Are you checking labs? Here's what I recommend. I think that can go a long way, and I think one of the challenges in laboratory medicine is we're kind of a black box. People send us samples and they expect results, and it's sort of like a vending machine mentality. And I think the more we can do to be a face and a clinician, it only helps our specialty. And I really think it helps patients to have someone who is not in the moment of dealing with the bleeding, to be objective and thinking about just the transfusion aspect. I think it only adds to the care of the patient.
So if that's the case, how do you get it to happen?
Well, I can tell you from going around and talking to people, when I talk to crowds like this, there's always 1 or 2 people and they're often surgeons, that are like, oh, this makes so much sense, how can I make it happen? And then you go to the residents or the residency program director or whomever, and just to operationalize that is really hard, and people have a lot of other things that they're already doing. How do you pull them away from whatever thing that they're working on to do that, and the systems issues if it's not already happening. Probably baby steps. I'd start with making the phone call. That's the easiest, I think, to operationalize. If the blood bank gets a massive, a pathologist gets on the phone with the OR. Once you make the phone calls, it's actually sometimes easier just to walk over. So baby steps, I guess, is what I would say.
Well, that's responsibility of a pathologist as a physician.
I agree. I think we're in the minority. I think most people go into pathology for reasons of, maybe not wanting to be right at the bedside and wanting to have time to look at slides and make a decision. And I think that getting them out of that zone is for many really out of their comfort zone. So to change the culture. Mike.
We get really nice data to show that laboratory measures tenders when they're using a plasma.
Yeah.
Did you ever come up with some recommendations
Yeah, so there's a lot of work going on right now. We just submitted a paper looking at titers and looking at how frequently they are high and whether there's any seasonal variability and what the numbers should be. And it's a numbers game, right? If you pick a titer that's very stringent, you disqualify a large number of plasma. If you pick one that's not, maybe you increase risks of complications. I think right now everyone's kind of making their own local decisions. And the methodologies differ too, which makes the numbers hard to compare.
How long does it take to measure a titer?
If you can get your plasma to have segments, you can measure it in advance. If you're trying to do it while the plasma's going out the door, it takes probably a good 15 minutes, I would say, depending on what else is going on.
It also depends if it's a cutoff or a titer.
Yeah.
If you're using a single cutoff,
Single
it's very
deletion.
fast.
Yeah. Robin.
Thank you, that was really awesome.
Oh, thank you. That means a lot from a pediatric pathologist.
As you look back at sort of the beginning of your research career, what resources in your department and outside your department were particularly valuable to you that you would want to steer other new researchers towards early on? For example, statistical support or writing or like networking, stuff like that.
Yeah, I mean, I think it's important to, when you're just writing, to write with someone who knows what they're doing. And I feel really, really thankful that I got to work with Wayne Chandler because he knew how to do this. And he actually mentored me, and not just like, here, do this, and then I'm gonna rewrite it for you. Like, he actually made me go through the process and sat with me and worked with me and helped me understand how to write scientifically. I think then as I got along farther in the career, finding collaborators that are true collaborators, people that are really gonna shoulder the work with you and, you know, give feedback and help bounce around drafts. I think learning very early on to have a very thick skin about seeing your work totally torn to shreds when you send it to someone else. It's taken me a while, but I really, really believe, and I teach my residents that like papers get better because lots of hands work on them, and I've never had a paper that's been worse for having had multiple people weigh in and edit it. It's hard. We know it feels like your baby and it comes back and it's all red. So yeah, I think finding people that are really invested in that so you're not alone. Seeking out resources. I've definitely had to learn statistics and things as I've needed to, and finding people within the institution that can help with that. It is a journey. It's not something any of us know how to do when we get started. So, you know, just being tenacious and seeking out help and not being afraid to put yourself out there, I think, is what I would say.
Any other questions? Thank you very much.